It's a clinical perspective. I've got a few points on research. What I'm trying to do is set a scene. So I come from King's College. We know about 30% of adults, as Nicholas just said, have evidence of erosive tooth wear. But it's preventable. Now that can be achieved by diet, which we'll talk a little bit further on. You can help that with a toothpaste and or a mouth rinse. And you can, if appropriate, provide restorations, but they themselves have disadvantages. But even when you've applied a restoration, you should be continually thinking about prevention. But it has challenging clinical decisions. The cost of tooth wear we'll discuss later. The confidence of the dentist in providing the restorations where appropriate, and a question mark on their longevity. So we know from this study, which is across Europe, around about 30%, in fact 29%, had evidence of tooth wear, which would be visible to the dentist. That 3% would almost certainly be visible to the patient. So we have a condition that is prevalent. It causes dentists concern. And what do we do about it? Well, I suspect not many of you in the audience are young. 20 years ago I had hair. But one of the conditions of tooth wear, one of the implications of tooth wear, is as you get older, your teeth tend to wear. But within that, there's a group of people who have very high tooth wear rates. And we're not entirely sure why at the moment. I'll share some of that findings with you shortly. But we have learned over time that the two types of teeth to sort of look at to assess whether or not somebody's likely to present with tooth wear is the labial or buccal surfaces of the upper incisors and the occlusal surfaces of the lower molars. And they're kind of key indicator teeth for you to ensure or check to see what happens. Because what we don't want to happen is something like this. This is a picture of one of my postgrads 10, 15 years ago. She was a dentist. She was very aware of her appearance. What do you do with these teeth? Do you place restorations on them? And if you do, within a relatively short period of time, they discolour. Or do you leave it alone? Most importantly, you hit the risk factors. Because you don't want, all these are different people, you do not want the tooth wear from going from one step to the next. Because patients will see that, and they will be concerned about their appearance. So it's not what you eat, it's how you eat it, as far as the diet's concerned. Reduce snacking. On fruits between meals, that's a common dietary information, isn't it? It's the same thing we say with caries, except the bad one there is sugar. In this one, it's fruit, and there's the conflict. Fruit is important for our health, we're told that. It's 7 to 8 pieces a day, and if you're in Australia, it's up to 12. But it's how you eat that that's the important component. Avoid sipping and drinking. If you are a dentist and you've ever treated a wine taster, you'll know how destructive that process can be. So we investigated this, or rather Saoirse did, looked at 60 patients, those with severe tooth wear, and they split randomly into two groups. One group got standard dietary advice, that is, stop drinking acidic foods and drinks. The other one was hit with the if-then plan. So if they were eating acidic foods, well, why not consider something like a banana? Why not think a non-erosive fruit? Keeping up the concept of healthy eating, but focusing it. Because if you tell me, particularly after today, I can't have another glass of red wine, I'm going to listen very carefully. I might go for white because it's a bit hot, but I like red wine. But it's how you consume these things which is important. Each patient got an impression. Mean age was around about 37, and we were pretty much gender matched. And this was the impact of that dietary information. We got half the progression of tooth wear in those who got the erosive dietary information, telling them not being no, but actually think about another way of consuming these fruits. So you can make an impact on somebody's life. Because we know now, increasingly, it's a multi-factor process. Dietary acids initially erode the surface. If nothing else happens, and we don't continually get an impact of erosion, that surface will remineralize. But if you don't, then you might get progression. And this is where we'll find out a little bit later about what toothpaste can do with fluoride and calcium-based products, one of which is obviously the Unilever product. And this is that patient I shared with you at the beginning, 10 years later. Nothing's changed. That is the best outcome because we took a preventive approach. And she's still a dentist and doing very well. Because what happens when you start to restore teeth, you can certainly improve their appearance. As we heard yesterday in the Erosive Toothwear Symposium from Alex Milosevic, composites can work. But they do deteriorate over time. And some patients appreciate that, and some patients don't. And these things will fail, and some patients will accept that process, and some don't. And when you do change the appearance with crowns, okay, they last longer, and some patients will accept that and some won't. But the cost to the tooth is that, because we've had to cut the tooth down. So your impact on patients can be profound. And how much does it cost? Well, again, Saoirse looked at this. 5,000 to 31,000 pounds to restore a mouth. That's a lot. I know pounds isn't the euro. Pounds isn't much anyway at all at the moment. But it's complicated prosthodontics. It's expensive work. And then they have an uncertain longevity. So what would you prefer? Would you prefer something like this? Or would you prefer to prevent? I know what I'd say. Because when we did the audit on Composites at King's, 35 patients, we had a reasonable success rate, but 61% of them had a fracture within a few months. So I can't cure tooth wear. I have to have at my disposal prevention. So, what have we got? We've certainly got a prevention option for early or mild levels, and I'd argue at severe levels as well. It's cost effective. It's important at all stages of the pathway. But restorations, they change the shape. It's an irreversible process, and it can mean removal of tooth tissue. So we need to prevent. Probably most importantly from the diet. Almost certainly from the role of toothpastes, and possibly from mouth rinse. So we have a common condition. In most people, as we get older, it's a slow process, but as we know, certain people go through a very quick progression. From my experience, appearance is the main motivator for patients wanting to receive care. And when that care is delivered, prevention, in my view, is the strongest and the most important component of that care. We can change behaviour, so you can have an impact. You've got to think about toothpastes. And only, if necessary, should you consider restorations. Thank you.
I will talk about what we currently know about erosive tooth wear and its consequences. Briefly, I will give you an outline on the difference in terminology between dental erosion and erosive tooth wear, and then we will talk a little bit about prevalence of erosive tooth wear, what are its consequences, and how to prevent them. As we know, dental erosion is the loss of tooth substance caused by chemical processes due to acid exposure, but not involving bacteria. The acids involved in erosion have a very low pH, which leads to undersaturation with respect to both hydroxy and fluorapatite. Thus, these two mineral phases are dissolved from the surface and it becomes softened. And this softened layer is more vulnerable to abrasive forces that would have little or no impact on a sound dental surface. And this will lead to removal of a layer of enamel, what we call erosive tooth wear. So the term dental erosion should be used to describe only initial partial demineralization caused by the action of acids, which means that it is a chemical process, while erosive tooth wear also involves the action of abrasive forces, which means that it is a chemical and mechanical process. It's important to highlight that sometimes we can have substantial wear without involvement of abrasive forces, as for example in patients presenting vomiting, where there is prolonged and repeated acidic challenges. For many years, erosive tooth wear was a condition of little concern in the clinical practice, in dental public health, and also in dental research. It is amazing how the number of publications on this topic increased in the last 30 years. Does this mean that erosive tooth wear is new? Absolutely not. There are reports showing erosive tooth wear even in medieval skulls. What happened is that we have now a change of perception and people are getting more and more aware in the occurrence and necessity to prevent erosive tooth wear. The reason for this increased interest in erosive tooth wear is the decline in the prevalence of dental caries. Nowadays, in the past it was relatively common to see an oral cavity like this with extensive caries lesions, while nowadays in many countries most of children are caries free. And this obviously opened space for the diagnosis of other lesions, such as erosive tooth wear. And how prevalent is erosive tooth wear? There are many publications worldwide, but I like to mention this one that is a systematic review that evaluated the prevalence of erosive tooth wear in the permanent teeth of children and adolescents. And the authors estimated a prevalence around 30%. Is this concerning? Yes. Why is it so concerning? Because the condition, the erosive lesions, they progress a long time. So we must implement appropriate preventive measures in due time in order to avoid the consequences of erosive tooth wear. And what are these consequences? As we mentioned, erosive tooth wear is progressive and serious consequences can occur if appropriate preventive measures are not taken. So transparency is often the first visible sign of erosive tooth wear, and it occurs because enamel becomes thinner as the tissue is removed, and this sign is more evident on the incisal edges of the anterior teeth. Often this is not perceived by the patient, only the dentist can detect this at this stage. At more advanced stages, we can see yellowing and discoloration of the teeth, which is a consequence of enamel removal exposing the dentin, and also it is a consequence of absorption of colored pigment components from foods and drinks. And this is often the first sign that is perceived by the patients themselves. With advancement of the lesion, we can have changes in tooth morphology. For example, chipping of the incisal edges, shortening of the maxillary incisors, leading to a loss of vertical dimension, which can have very serious aesthetic and also functional consequences. And aesthetics is so much impaired that patients frequently avoid laughing or even speaking, and this causes a great reduction in self-esteem. So it is really a problem for the patient. Also, with exposure of dentin, we can have sensitivity characterized by short, sharp pain sensations that in fact are a response of the pulp nerves to a change in fluid flow in the dentinal tubules. And around two-thirds of patients with erosive tooth wear might experience sensitivity. And this is really a problem because it can cause a reduction in oral health related quality of life. There are reports on this, and also there are reports showing that this quality of life is considerably improved after a treatment of sensitivity. So knowing that erosive tooth wear can cause important consequences with aesthetic and functional problems as well as pain, it is very important to avoid this. And how can this be done? This can be done by early diagnosis, as Professor Bartlett mentioned, and also implementation of appropriate preventive measures. These preventive measures, they should fight the causal factors that could have nutritional or patient, these factors can be related to nutrition or to the patient itself. Regarding the nutritional factors, the composition of foods and drinks is very important, and usually low pH and higher buffering capacity are the main risk factors, while calcium concentrations are the main protective factor. In this aspect, it is important to highlight that there is no fixed critical pH below which erosive tooth wear is expected to occur, as we commonly mention for caries. This comes from the fact that the erosive tooth wear is dependent on the degree of saturation of the beverages with respect to hydroxyapatite, which is a function not only of the pH, but also on the calcium and phosphate concentrations of the beverage. For example, in this table, here we have natural yogurt. Despite it have a pH of only 3.9, it will not erode the tooth surface because it has a high calcium phosphate concentration, and even at this low pH, it is still saturated with respect to hydroxyapatite. Regarding the factors related to the patient, it is very important that appropriate eating and drinking habits are followed, as Professor Bartlett mentioned. Increased frequency and duration of acid contact with the teeth will increase the risk of erosion. For example, Positioning a straw in the anterior region of the mouth or even nipping from a bottle can increase the risk of erosion because they increase the contact between the acids and the tooth. Also, consumption of acidic snacks between meals should be avoided because this increases the risk of erosive tooth wear. An important factor related to the patient is how the patient performs oral hygiene. In this figure, it's about an in situ study where we evaluated the effect of delaying the brushing 60 minutes after the acidic challenge, and we could see a significant reduction in enamel wear. However, as we can see, the wear was still substantial and probably no clinical significant effect might occur, which is in line with epidemiological studies showing no association between tooth wear and the waiting period for tooth brushing after breakfast. So it's not useful to delay tooth brushing after the erosive challenge. This will not prevent or reduce the rate of erosion. Another important issue related to oral hygiene is the brushing force. So patients with erosive lesions with increased risk, they should apply toothbrushes with slight pressure. Also related to oral hygiene is the abrasivity of the dentifrice. So toothbrush abrasion is influenced mainly by the abrasivity of the dentifrice, but the stiffness of the toothbrush bristles is of minor importance. Also, the presence of fluoride in the dentifrices is important to prevent erosive tooth wear. Here we have results both for enamel on the left and dentin on the right, showing that the degree of wear is significantly reduced in the presence of fluoridated dentifrice. And as we can see for dentin on the right, there is no additional benefit on the use of dentifrice with high fluoride concentration. So using a 5,000 ppm fluoride dentifrice was not better to reduce wear than the use of a regular dentifrice. So patients with erosive lesions should use fluoridated dentifrices with low abrasivity for the oral hygiene. There are some conditions that increase the presence of gastric acids in the oral cavity, such as anorexia, bulimia, and reflux. The odds ratio for erosion increases 12 times in patients with eating disorders and more than 19 times when self-vomiting is induced. So patients with reflux or bulimia should be referred to a doctor for causal therapy. Also, very important among the patient-related factors is the quality of saliva. Saliva plays an important role in minimizing wear because of its buffering and remineralizing capacities, and also to its capacity to form the acquired pellicle. So in conditions where we have a decreased salivary flow, which leads to low pH and low buffering capacity, we have a higher risk of dental erosion. So chewing a tooth-friendly gum might be a good measure to increase the salivary flow and to prevent postprandial reflux. In summary, we can have important consequences arising from erosive tooth wear, such as transparency of the incisal edges, yellow and discoloration of the teeth, loss of vertical dimension with impact both on aesthetics and function, and also pain, which significantly reduces the patient's quality of life. Thus, in order to avoid these consequences, it is very important to early diagnose erosive tooth wear and to implement appropriate preventive measures that are able to fight the risk factors. I would like to acknowledge our research group, our collaborators from Brazil and from abroad, and also, again, Unilever for inviting me for this presentation, and you all for your attention. Thank you very much.
In my group at Warwick, the Warwick Electrochemistry and Interfaces group, we're really interested in developing new techniques that can be used to look at interfaces and interfacial processes, and we're very interested in processes that happen on enamel surfaces and the way that you can understand and characterize those processes. So I want to share with you some of the recent work that we've been doing in this area, particularly looking at erosion and the analysis of erosion processes and acid dissolution. So what I'll also talk to you about is that there are many interfacial processes that happen on the local scale in the oral environment that we might want to probe, and this technology that we've developed, the Warwick Electrochemical Lab on a Tip, is a technology that can be applied to a whole host of processes in addition to erosion. And then I will tell you about a few applications looking at localized erosion, some new work that we've done, which is to really look at the charge on a surface and how the charge on an enamel surface changes under erosive conditions, and how we can use that to actually detect very early stage erosion and remineralization processes. So this is really just a highlight slide of some of the things that we've been looking at with our lab on a tip. So we basically, as I'll show you, we have a platform which enables us to look at the microscale and nanoscale. We've done some work looking at single cellular processes. We've done quite a lot of work looking at dentinal hypersensitivity and the flow of fluid through dentine. And as Marilla mentioned, that's an important process or consequence of acid erosion. We've developed local pH and calcium probes that can be used to map calcium concentrations near surfaces or pH near surfaces. And then we have also this ability to make a large number of erosion measurements very quickly in a very small footprint that I'll tell you about. So this is the lab on a tip idea. So what we wanted to do was develop a platform where you have a very simple nanoscale probe that's easy to make and that's very versatile and that can be used in a number of ways. And I just show you three examples here. Something called scanning ion conductance microscopy, which is a local conductivity cell. And I'll show you how we can use that to measure the topography of surfaces, also the charge on surfaces. We can combine this with electrochemical probes as well to measure things like pH and redox activity at the local scale. Or we can actually bring small droplets to surfaces for very defined periods of time, from a few milliseconds up to seconds or minutes, and then look at the consequences of that. All of those probes can be used in a very versatile way, interchanged on this platform, where we can intelligently move a probe around a surface and make these various measurements. And one of the things we like about this platform is that we can make these very small scale probes very easily using a laser pipette puller. So you basically just take borosilicate or quartz tubing and you can pull it to a sharp point. You can get this tubing with 2 channels or 4 channels. You can fill some of those channels with ionophores to do potentiometric measurements. You can fill them with metals or carbon to make redox measurements, or you can leave them open and fill them with electrolyte solution and use them as a conductivity cell. So very, very versatile platform. And you can see here from this image that we can characterize those probes with microscopy and in other ways. So we have a very robust platform as well when it comes to making quantitative measurements, which is something that's very important to us. So here's an example from a couple of years ago where we were using this scanning electrochemical cell microscopy invented at Warwick as a way of probing localized dissolution processes. So the idea here is you can do a series of acid challenges on a surface. You fill, in this case, it's a theta pipette. It has this theta shape at the end. There are 2 channels. The 2 channels have an electrode inside. We can apply a bias between the 2 channels to cause ions to move between the 2 electrodes and measure a current. And that allows us to land a meniscus in contact with an enamel surface for a predetermined period of time and then look at the consequences. So as I say, we can fill that pipette with various types of acids to carry out this acid challenge, and then we simply move that pipette point-wise across a surface for preset times. So here, for example, we might go from 1 second up to 15 or 16 seconds. And we will then look at that surface afterwards and see what's happened to the surface using various techniques. And this image here gives you an idea of the footprint of this measurement. So the image there, as you look at it on the right-hand side, across is about the thickness of a human hair, and in the center there we've made over 100 different acid challenge experiments for predetermined periods of time. And you can see the consequences. There's a very small amount of erosion or acid-induced dissolution of the surface. And so what this lets us to do, because we're doing this on a very small footprint, we can actually take a small piece of enamel and remove or eliminate to a large extent any biological variability. We can then pattern that enamel surface and treat it in various ways, and then look at the effect of various treatments on the same piece of enamel. So you can see here, for example, we have an experiment where we look at the native polished enamel, and then we look at 3 different types of treatments on that enamel surface. So this, as I say, removes to a large extent biological variability and lets us really look at how effective various treatments are. So this then gives you an idea of the information that we get from this acid-induced dissolution experiment. You can see here a series of pits on the surface. They've been formed for different amounts of acid challenge, ranging, as I said, from 1 second up to a few seconds. And we can do AFM measurements afterwards, or we can do interferometry afterwards, and we can very accurately measure the extent to which the enamel has been dissolved away. And you can see from this data shown here that a treatment that involved 1,000 ppm fluoride and zinc had a big effect in reducing acid-induced dissolution, really echoing some of the things that Marilla told us about. So as I mentioned to you, one of the things we like about this platform is that the pipette geometry is very well defined. And as we know, something like acid-induced dissolution, it's a fast process, and it involves transport of protons or other acids to the surface, and the erosion process. And so we need to understand how things move to the surface, and we can do this with this configuration. So we can build finite element method models that treat diffusion and migration of ions in this pipette and allow us to pull out a rate constant for the rate of acid attack on the surface. So it's a very quantitative technique from that point of view. So we run finite element method models that basically produce data that's shown here. So here what we're looking at is the calcium flux on the vertical axis, and that's something that we measure directly by measuring the volume of the etch pit for a particular period of time. We know the tip diameter, or what we call the pipette diameter, and we can measure the etch pit diameter as well from our AFM measurements. And so then, using that information, we can determine what the rate constant for acid attack is. So usually, acid attack of enamel is thought to be just a diffusive process. But here, with this very small scale system, we have such high rates of acid transport to the surface, we can actually measure for the first time the rate constants for acid attack. So you see here we measured the rate constant for enamel, attack on native enamel, and then we looked at various treatments, and we found that a very effective treatment was this calcium silicate plus fluoride together, and so that's the NR5 technology that's used in Regenerate that Andy will talk about in his presentation. So that was the most effective of the treatments that we looked at in terms of reducing acid attack. And if I may, just for the final part of my talk, I'll tell you about this new approach that we've adopted, which is scanning ion conductance microscopy. As you can see here, it's a conductivity cell. We have 2 electrodes. One of the electrodes is inside a nanopipette, and we apply a bias between those 2 electrodes. A current flows, and the current depends on the ion concentration and on the geometry, the overall geometry of the setup. And the geometry, one of the important factors in the geometry, is the distance between the probe and the surface. So what that means is we can use the current to actually track the topography of a surface, rather like you do with other scan probe techniques like AFM, but we can also use it to tell us about other ion properties, and particularly the charge that's on a surface. So basically what we're able to do is to essentially characterize and map the change in the charge across the surface by basically sensing the double layer. And so what you can see here is we've got the finite element method simulation results. If we apply a very small bias, our probe response is sensitive to topography, so we can map out topography. If we apply a large bias, the probe response becomes sensitive to charge on the surface. So we have a technology to measure topography and charge together. So again, we can do finite element method modeling to basically analyze all of our data. I won't go through that in any detail. I'll just give you a couple of examples. So here again, we're looking at living PC12 neurites. You can see on the left-hand side, as you look at that, there's an optical image. You can see our probe. You can see part of the neurite. And then you can see the SICM topography, so we can map out the topography of that living cell, and then we can actually, for the first time, measure the charge on the surface of that living cell as well. And then we've used this technology now to look at enamel, so we've prepared, or Bryn Jones, who's in the audience, has prepared these enamel blocks in a standard kind of way, polished them to a very fine finish. You can see here an AFM, atomic force microscopy, image of the enamel surface, and we can see the characteristic rod structure, okay? So with our technology, we can also, with the SICM, what it gives you that AFM doesn't give you is actually the charge on the surface. So we can see that there's a variation in the charge across that surface, and there are regions of more negative charge on the surface in the kind of the regions between the enamel rods. Okay, so then the question is, what happens to this surface if we challenge it with acid for very brief periods of time? So what we now do is we prepare the enamel block as before. We're going to then characterize the charge on the surface. We will then do an acid challenge, so it might be with citric acid or phosphoric acid. They're the two acids we've looked at so far. Then we'll replace the electrolyte, and then we'll see what's happened to the charge on the surface. And the acids we've chosen are there to sort of mimic carbonated drinks and fruit. And what we see is something that's really quite dramatic. In the case of citric acid, we see a huge change in the surface charge. It becomes very negatively charged, and we think this is because citrate can complex well with the calcium, so it either removes preferentially the calcium, or it adsorbs onto the surface and neutralizes some of the positive charge from the calcium ions. And the phosphoric acid, there's very little change in the surface charge. So this is really looking at the effect of acid before other techniques are really able to see any damage to the enamel surface. Okay, so this is the very earliest stage. We can then see to what extent remineralization procedure restores the native charge that we'd expect to see on enamel. So we do the acid wash, and then we do a simple 30-minute remineralization at 37 Celsius with a phosphate and calcium-rich medium. And then we look at the surface. So here again, we're looking at the surface before citric acid. It has a moderate negative charge. When we challenge it with citric acid for just 30 seconds, there's a dramatic increase in the negative charge on the surface. And then after 30 minutes remineralization, there's a partial restoration towards the native state. Okay, so these new techniques really allow us to look at very subtle changes in the surface and how different treatments will protect the surface or encourage remineralization. So it's been a wonderful opportunity to really present to you some of these new techniques that are not really used much in dental science at the moment. I think they have a lot of potential. Scanning electrochemical cell microscopy really lets you do many localized measurements across a surface in a matter of minutes, look at the effect of different treatments, remove some of the issues around biological variability. And then this new technique that we've been developing with support from Unilever is to look at the early stages in enamel surface charge and what happens when we have this initial acid attack. And we've seen these very dramatic and exciting results, a big change in the surface charge of enamel. And these technologies can be used across a wide range of processes and problems in the kind of dental science field, we believe. So I'd like to thank Bryn Jones, who's done much of the work I talked about in the latter part of my talk. He's sitting in the audience, and my colleagues at Unilever. Always good to have good conversations, and for their funding for the studentship that Bryn's been undertaking. Thank you.
So the overview of my talk, I'll give a brief introduction about enamel minerals, and then we'll focus on calcium silicate and sodium phosphate remineralization technology with a particular focus on mode of action and a selection of in vitro and in situ efficacy studies on enamel. And then I'll finish with a few concluding remarks. So here's a cross-section of enamel. And I'm always amazed at how beautiful it looks under the scanning electron microscope. You can see that the enamel crystallites are orientated together into bundles, and this structure helps to give enamel its aesthetic beauty as well as its inherent strength. And those crystallites are made up of hydroxyapatite, which is essentially a calcium phosphate-rich mineral. However, acids from plaque bacteria, and as we've heard this morning during the symposium, acids in diet can lead to demineralization of enamel. But fortunately, the saliva in our mouth containing calcium phosphate can help remineralize the enamel. And that's demonstrated in the upper equation where calcium phosphate can help to regenerate the calcium hydroxyapatite within the tooth surface. But sometimes this process can be overcome by excessive acid exposures, and so you get net demineralization. So we wanted to identify some technologies that could help augment the natural process of enamel remineralization, and we came across a combination of calcium silicate and sodium phosphate salts as our key active ingredients. Essentially, they combine together to deposit particles on the surface where they're able to nucleate the formation of hydroxyapatite on the tooth surface at the microscopic level. So this technology is presented in two types of oral care products. The first is a toothpaste containing the calcium silicate, phosphate salts and fluoride at 1450 ppm. And the second product is a dual phase gel. The first phase is a calcium silicate phosphate fluoride phase, and the second phase is just a simple fluoride phase. And these are combined together in a one-to-one mix in a mouth tray and applied to the teeth. And the recommended use for these products for the toothpaste is as a standard toothpaste, so use it twice a day, whereas the dual phase gel is for 3 consecutive daily applications per month in conjunction with the toothpaste. So let's turn our attention to the mode of action of the calcium silicate phosphate technology. This is a schematic showing that as you apply the product during brushing, the active components of calcium silicate phosphate are released, they are combining in the saliva, and that leads to deposition of calcium silicate particles onto the tooth surface. There they can nucleate the formation of hydroxyapatite on the surface. Let's look at some of the evidence to support that. So this is an in vitro experiment where we took some enamel surfaces and brushed with calcium silicate phosphate toothpaste. And the left-hand SEM image shows that you can see all these little white specks, so that's the deposition of the calcium silicate particles immediately after brushing and rinsing. If we then continue the treatment for a series twice a day brushing for 4 weeks, we get continued build-up of a layer, and the middle SEM image shows a cross-section where there's a deposited layer of material. And using the scanning electron microscope and energy dispersive X-ray spectroscopy, we analysed that surface to show that it contains calcium phosphate rich phases. We also wanted to investigate whether this occurs in the mouth. So in this case, we used an in situ model where enamel blocks were attached to the surfaces of volunteers' teeth, and they brushed with a calcium silicate phosphate toothpaste for twice a day for 4 weeks. Those samples were then removed for subsequent analysis. And again, we have a cross-section of one of the samples, and we could observe a deposition on that surface of that specimen, and that was indeed another calcium phosphate-rich material. We then did some further analysis to see what crystalline phases they were, and this time we used a focus ion beam on these kind of specimens to take out a very thin section from the deposit and from the underlying enamel specimen. And then these are placed into a TEM to undergo selected area electron diffraction. And essentially the selected area electron diffraction pattern of both the deposited material, the deposited material was in very good agreement with the patterns for both the underlying enamel and a HAP reference standard, indicating that we had formed hydroxyapatite on the tooth enamel specimen. So let's turn our attention to, well, what does this technology do in terms of remineralization and demineralization on enamel? And we've conducted a range of in vitro and in situ studies, and the objectives was to evaluate the ability of calcium silicate phosphate technology to promote enamel remineralization and to protect enamel from demineralization. And we've done studies both with the toothpaste on its own and combined use of toothpaste plus the dual phase gel. So the first experiment is an in vitro remineralization study. So here we take enamel specimens, and we first erode them with citric acid for 10 minutes so the surface becomes soft, and then we undergo a sequence of treatments as schematically shown here on the right. So working from left to right, they have a toothpaste treatment first thing in the morning. They then have a neutral buffer to simulate saliva for 6 hours, then a toothpaste treatment at the end of the day, followed by the dual phase gel for 3 minutes, and then into another neutral buffer to stimulate saliva overnight. And what we did, we tested the following formulation: so a calcium silicate phosphate toothpaste, the dual phase calcium silicate phosphate gel plus the toothpaste, and also a non-fluoridated control toothpaste. And we measured the surface microhardness of the specimens at baseline, following acid erosion, and after 1, 3, and 7 days of remineralization. And the results are shown on the next slide. So on the y-axis, we've got the mean surface microhardness values, and the red dotted line indicates surface microhardness after acid challenge. So any improvement in remineralization, we see obviously an increase above that line. And we can see after 1, 3, and 7 days treatment, a combination of the calcium silicate phosphate toothpaste and the dual phase gel gave significantly greater recovery of the enamel surface microhardness compared to a non-fluoridated toothpaste. We then conducted an in situ study to look at the effects of the remineralization. So this was a double-blind, randomized, controlled crossover study with 47 subjects. There was an independent ethical approval and signed consent was obtained. The study population was adult and female healthy volunteers, and standard inclusion-exclusion criteria was applied. The enamel specimens were prepared as 4 by 4 millimeter blocks, and they were pre-treated with acid with 0.3% citric acid to soften the surface for 25 minutes before placing onto the device. And the formulations tested, so the test formulation was the calcium silicate phosphate toothpaste plus the dual phase gel system. And then we had 3 control groups. It was calcium silicate phosphate toothpaste plus placebo gel, fluoride toothpaste plus placebo gel, and a non-fluoride toothpaste plus placebo gel. And the product application was that the dual phase gel was applied once per day on days 1, 2, and 3, and the toothpaste as normal toothpaste twice per day brushing. And the primary outcome variable was the surface microhardness of the inserts after 3 and 7 days in situ. And the results are shown here. So here we're on the y-axis, we've got percentage surface microhardness recovery after 3 days. And we can see that the calcium silicate phosphate gel plus the toothpaste was significantly better than the placebo gel with the fluoride paste. And this effect was continued at day 7. We've also conducted some protection studies, and this is one example. So here we're taking sound enamel to start with. We're mounting them in an interproximal arrangement, and then they're exposed to a cycling regime of saliva, product treatment, more saliva and citric acid for 7 days. And again, we're measuring the surface microhardness at baseline after 3 and 7 days. Our treatments are the calcium silicate phosphate toothpaste, calcium silicate phosphate toothpaste plus the dual phase gel for the first 3 days, a fluoride-only toothpaste, and a non-fluoride toothpaste. This is a schematic of the cycling protocol. It's a little bit more complicated than the previous in vitro study, but we had two different acid frequencies. So for the low acid frequency, at the start of the day, they go into whole saliva, then the morning toothpaste treatment, and then a cycle between saliva and acid for, twice in the day, followed by further saliva, and then a toothpaste and serum in the evening, and then the artificial saliva overnight. For the higher acid frequency group, it was the same protocol, but we had 4 treatments of acid during the day, and the time between artificial saliva was shortened. So the severity of the acid challenge in the high acid frequency is much greater than the low acid frequency group. So again, we're measuring surface microhardness. A lot of data here. And here we're comparing between treatment groups. And for low and high acid frequencies, both the calcium silicate phosphate treatment groups provide significantly more enamel protection than the fluoride and non-fluoride toothpaste treatment groups for both the low acid and high acid treatments. If we compare within treatment groups, so we're comparing now with their own baseline values. So for low acid frequency compared to baseline, both the calcium silicate phosphate treatment groups provide enamel protection, as there's no significant reduction in this experiment. However, for the high acid frequency compared to baseline, it's only the combination of the calcium silicate phosphate toothpaste and dual phase gel that provides enamel protection from baseline. So some concluding remarks. Calcium silicate phosphate technology has been demonstrated to form hydroxyapatite on enamel. Treatment with a calcium silicate phosphate toothpaste led to significant remineralization of acid-challenged enamel. The combined application of calcium silicate phosphate toothpaste and a dual-phase gel system provided enhanced remineralization versus toothpaste controls. Significantly greater rehardening of acid-challenged enamel from use of a calcium silicate phosphate toothpaste and dual-phase gel system was demonstrated in situ compared to a fluoride toothpaste. And finally, the calcium silicate phosphate containing products can provide greater protection of enamel from acid challenges than fluoride toothpaste. So one of the joys of working on such a project as this, you have the opportunity to work with a range of academics from all over the world, including some of these guys here, and it's been a real privilege to work with them on this journey, but also should acknowledge the wider oral care R&D teams in Shanghai, Kasali and Port Sunlight for their contributions. And finally, I'd like to thank you for your kind attention today.